Okay, time for part 2, part B, part II of the Persiflager's Infectious Disease podcast. The usual stuff I need to get out of the way. It's CMB accredited. I have no conflicts of interest to report. This is brought to you by the Persiflager's podcast at pusware.com, and the music is by my son. If you like this, listen to my Quackcast, and please write me a review on iTunes. How long does it take a sputum to convert to negative in someone with pulmonary tuberculosis? Well, this study outside of South America followed people with pulmonary TB and watched for both smear and culture conversion. And they followed people for 2, 4, 8, and 16, or should I say 2, 4, 6, 8, who do we appreciate, days after instituting therapy for tuberculosis. And here's what they found. Conversion of sputum culture was 34 days, and the mean time for smear conversion was 38 days. Now, these had big error bars. It was 34 days plus or minus 26 and 38 days plus or minus 32. But it is of interest that only half the patients had negative cultures within the first 4 weeks of therapy. What was the cause, or at least the association, for prolonged positive cultures during therapy? A lot of AFB on the initial sputum, cavitary lung disease, and long-standing tuberculosis. Now, obviously, if you had a multi-drug resistant strain, you're more likely to have positive smears and cultures. But this is important from an isolation point of view, and it's certainly of note that your patient needs to be in isolation at least until they have 3 negative smears, and that may take a long time. And we all are aware in this day and age how important it is to keep patients in the hospital as long as possible, because it makes both administration and the insurance plans very, very happy. There is now about a 45-second pause before the next podcast review of the literature. This is because of a foobar with GarageBand that would take me several hours to repair. And rather than spending several hours repairing this particular problem, I'm going to just let you listen to silence for a little bit. Aren't I a nice guy? Well, maybe not. I'll just keep talking. The next talk is at 3 minutes. So if you just wait to the 3-minute mark, you'll quit listening to my voice and you'll get to hear more about tuberculosis. Garage tunes can be a little wonky sometimes, and when you get these big gaps, it's such a pain in the ass to try and fix them. Oh, lucky you, here comes the next paper right now. So you treat their TB and all is well and good. They're cured, right? No more problems, correct? Of course not. Why else do you think I'm saying this? This was published in Chest in March of 2007 and was entitled Post-Tuberculosis Pulmonary Impairment. And unfortunately, if you've had pulmonary TB, you are likely to have ongoing pulmonary dysfunction. If you have pulmonary TB when compared to just patients with a positive PPD, or as they call them these days, latent tuberculosis infections, you had a 5.4 times higher likelihood of having abnormal PFTs, and sometimes they were significant. 59% of treated patients with pulmonary tuberculosis had a decrease in their FVC, their FEV1, their FEV1 over FVC ratio, and their mid-forced expiratory flow. And they were significantly lower than the comparison group. 9% of patients had pulmonary function tests that were half the expected value. So it would turn out that if you get pulmonary TB, you are likely to go on to have ongoing physiologic pulmonary dysfunction. As the end of the abstract says, for many persons with tuberculosis, microbiologic cure is the beginning, not the end, of their illness. Bum, 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 bum. The echinocandidate antibiotics are multiplying like bunny rabbits. I don't know, how do bunny rabbits multiply? Anyway, we've had caspofungin, and now there's mycofungin and angulofungin, and I'm sure there'll be other fungins to come. A study that was published at the European Infectious Disease meeting and summarized in Medscape looked at patients with candidemia who were randomized to receive either mycofungin 100 milligrams a day, mycofungin 150 milligrams a day, or the standard caspofungin of a 70 milligram load followed by 50 milligrams a day. When it came to clinical outcome, there was no difference in the three groups. About 70% had a overall treatment success. When they looked at mycologic cure, i.e. they got rid of the Candida, the results were the same. About 85% had a mycologic response. None of these patients had endocarditis, and none of these patients had neutropenia. The complication rates and side effects rates were the same. The majority of patients had Candida albicans, and the same number of patients had non-albicans Candida. So I think it's safe to say that these two drugs are non-inferior, that mycofungin at 100 a day is just as good as mycofungin 150 a day. And if you're going to be treating a Candida infection, the only thing you should use to decide what to use is the cost to your pharmacy. And if 100 a day of mycofungin is the cheapest, you should probably be using 100 a day of mycofungin. Like the echinocandidins, the imidazole antibiotics are also multiplying and looking for reasons to use them. Posaconazole in a series of 6 patients, which is just an extended number of anecdotes, was used in patients who had refractory histoplasmosis. All these patients had been treated with the other standard medications such as Ampho, Itra, Flu, and Vori, and when given posaconazole, 800 milligrams a day, all of them were cured. It's just something to keep in the back of your mind if you have a refractory case of histoplasmosis. For you connoisseurs of parasitic diarrheas, you've long known that there's a debate that goes back to antiquity as to when people get E. histolytica, why are some people asymptomatic, why do some people get dysentery, and why do others get liver abscesses? Is it the host or the organism? And it's never been known for sure which it is. It's long been suspected that there's been a difference in the organisms, and maybe that is indeed the case, as evidenced in an article in the Journal of Clinical Microbiology. They took patients who had E. histolytica diarrhea, E. histolytica liver abscess, or asymptomatic carriers, and did genotypes of their organisms, and indeed found differences. Now, these markers themselves, to quote the abstract, did not indicate the nature of the underlying genetic differences, but if you had an invasive organism, there were genetic differences compared to those that had dysentery. Now, this is interesting because it's long been noted that patients with liver abscesses usually don't have bowel disease and vice versa. This may go a ways to explaining that well-known clinical phenomena. You think that's bad? You should see what happens when I order a certain yellow fruit. A correction in the emerging infectious disease over some minor problems with a assay led to a table that showed the IgG toxoplasmosis seroprevalence in the United States, and I think it's worth noting here for 2 reasons. One, HIV patients are at risk for developing toxoplasmosis, and you can predict what the possibility is that they'll be seropositive in advance, and also it's an issue in pregnant women. Pregnant men, of course, are spared. So what are the rates, you ask? Well, if you're a Caucasian, it's about 15%. If you are either Hispanic or African American, your chance of being seropositive is about 18%. Not unsurprisingly, the rates go up with age, primarily because you eat more raw meat as you get older. And if you're foreign born, your rates are about 30%. So that's just something to consider in patients who have risks for development of toxoplasmosis. So what happens when you get Plasmodium vivax? Well, you can get reactivation after treatment due to hypnozoites coming out of the liver. Now, when these hypnozoites come out, it's always been assumed that it's the same infecting strain. However, they did a cool study, and I think this is really cool. I don't know why anybody does ID when you got stuff like this to read about. But they looked at the Plasmodium vivax in patients during the acute infection, and they looked at the Plasmodium vivax in the relapse, and they found that over half the time, usually around 75%, they had a different parasite as judged by genotypes. So when patients reactivate their P. vivax, it's not the same infection come back, it's a different infection. So people are often infected with more than one population of Plasmodium vivax, and they're hypnozoites. You are getting sleepy. When I snap my fingers, you will go on to iTunes and write me a good review. Now you will wake up as if nothing happened. Now there's something even cooler about Plasmodium vivax. Let's say you're an Australian soldier from East Timor and you get multiple bites with multiple mosquitoes. Well, there's a lot of variety of Plasmodium vivax in East Timor, so you're likely to have multiple lineages hiding out in your liver. Now, what's cool is that every time you relapse your Plasmodium vivax, you only relapse with one of the multiple strains found in your liver, and the others are suppressed. So that every time you relapse with a different strain of Plasmodium vivax. I just think that's neat. The other problem in East Timor is that there is tolerance to primaquine by vivax, so patients can relapse despite therapy. And so you may have one strain of vivax in your liver that is susceptible to primaquine, and you may have another strain that has tolerance. So you can't rely upon a single course of therapy for Plasmodium vivax to eradicate it, and you have to watch the patient to see if they relapse. I mean, this is just so cool. They postulate in this study that each vivax has a different biologic clock that's ticking, and that when it goes off, it gets in the bloodstream, and that each strain has a slightly different clock, so that's why you only get one organism multiplying to cause malaria. That is just a hypothesis that meets a mathematical model. Whether that's true or not is yet to be elucidated. Just an interesting article on the prevalence of neutropenia in the United States that was published in the Annals of Internal Medicine. This is normal white counts in normal people. And they found that blacks had, on average, about 800 less white cells than Caucasians. Both had normal white counts, so this did not represent any physiologic predisposition for infection that I could see. But like other labs, there is some differences among the races. The more interesting thing I thought in the study was that smokers had a markedly lower white count by about 1,000 compared to non-smokers, regardless of age or sex or race, and that smoking, amongst its many side effects, is a decrease in your peripheral white count. Again, not into the range where one would expect an increased infection risk, but it ain't helping you much if you're a smoker. So you have someone with a spinal implant infection. They've had a back fusion, they've had an implant, now it's infected. Do you got to take it out? Well, if the infection occurs within the first 30 days, if you debride the heck out of it, give long-term IV then oral therapy, treat it as you would a prosthetic hip infection, then you have a almost 90% chance of salvaging the implant. Now, if it's a late infection, i.e. it occurred 30 days after the surgery, your chance of salvage, according to this Clinics of Infectious Disease article, is not as good. In patients with late infection, the majority needed removal of the prosthetic device and the implants in order to get cure of their infection. And even then, they need a long-term therapy as well. So, as usual, early infections of prosthetic material and implanted devices are easierly treated than late infections of these devices. Any surgeons listening to this or surgery wannabes? Well, guys, guess what? Antibiotic prophylaxis will help prevent your surgical wound infections. Duh. That's been known about forever. But the interesting study published in Clinics of Infectious Diseases looked at surgical site infections following total hip arthroplasty. And the single most important thing you could do was to give your antibiotics before you made the damn incision. Jeez, talk about the obvious. But anyway, this study showed very clearly that if you got antibiotics before you had an incision, you had the least chance of getting an infection. And that the other things that were associated with infection or getting your antibiotic after the incision or a prolonged surgery. Now, the interesting thing in this study is that prolonging the prophylaxis after the surgery made no difference in the infection rate. And, unfortunately, antibiotic-impregnated cement did not help either. But this goes to show you, and this was a study that was done in the New England Journal of Medicine last century, that your best bet for getting good outcomes with your antibiotic prophylaxis is to have it on board with your maximal tissue levels at the time you're doing the incision. Next up, water is wet, ice is cold, fire is hot. 2 more studies on the statin front. Those who have been listening to this podcast have heard many articles about how statins can affect outcomes in infectious diseases. This one, published in Chest, showed that patients who are on 4 milligrams a day of statins decrease their death rate from pneumonia by 40% and their death rates from COPD by 83%. So yet another study to show benefit of statins in a case-controlled study in patients who go on to develop infections. A similar study was published in JAMA that looked at statin use and hospitalization for sepsis in patients with kidney disease. And again, in this study, statins was, quote, strongly and independently associated with a reduction in the risk of hospitalization for sepsis for patients who had chronic kidney disease and were receiving dialysis. There's now a lot of retrospective studies to show that with sepsis and a variety of infections, that if you're on statins, you have better outcomes. This truly is the wonder drug that works wonders. And its utility awaits good prospective randomized clinical controlled trials to show that it truly is effective for these processes. But long-time listener to this podcast know that I keep harping on statins and polymorphisms. But you are so up to date for listening to this that you are just so far ahead of your colleagues who are waiting the drug company meal to learn about this stuff. So that brings us to the end of another Persiflagers podcast, a review of the infectious disease literature with snarky commentary. This is Part B, Part 2, Part II for April 1 through 15th, 2007. References, including some not mentioned in the podcast, are available on the website. CME accredited. Take the online quiz. Get some free CME. Free. Brought to you as always by Pusware LLC, the publisher of the Persiflagers Annotated Compendium of Infectious Disease, Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at pusware.com. If you like this sort of nonsense, check out my Quackcast, available on iTunes. Bandwidth ain't free, so feel free to purchase the compendium and support this podcast. If you can't give me any money, hey, write me a review on iTunes. I don't think I've ever mentioned that before. Copyright, the Creative Commons license. The music is of my 12-year-old son, improvising on the guitar. You should hear him now that he's 14 and has a solid body Gibson. The boy can play. Feel free to send comments to mcrislip at pusware.com. I would be interested to know for my 3 listeners if you would prefer more detail, less detail on the subjects at hand, more or less time, a stronger editorial hand on what I report. But idea is so endlessly interesting. It's hard to hold back. Otherwise, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.